This technology is quietly solving the rural healthcare access crisis. Welcome to Health Elevated, a program dedicated to helping you live your healthiest life possible. I'm Dr. Fowers, and I co-host the program alongside Dr. David Hedges. Today, Eric Liston joins us, the Vice President and Chief Clinical Shared Services Officer for Intermountain Health. Be sure to stick around for our segment, 1 Minute for 1%, where Eric will share in 1 minute something you can do to improve your health by 1%. All right, Eric, David, rural healthcare. It's said to be a crisis, but what is the crisis? People live in rural areas. There's not a problem with that, right? So rural healthcare. Why is rural healthcare? I'm having a hard time saying that word. A crisis, or is it even a crisis? Am I wrong about what I'm even proposing here? Eric, let's start with you.
Well, first, I just want to say I'm thrilled to be here. I'm a grown adult, but this is the first time I have ever participated in a podcast. So I'm thrilled, excited, but I'd lie if I wasn't a little nervous to be here as well. So, but this is a pleasure, and I'm grateful to share some thoughts today. So I think this is one of those easy answers. There are crises in rural healthcare, and you don't have to go too far or read too many articles or look at any type of healthcare industry newsletter to demonstrate that there are crises in rural healthcare. And I'll name a couple of the issues. Number one, undoubtedly, every state besides a couple have had rural hospitals close, shutter their doors, stop providing care over the last several years. Luckily, the state of Utah is one of those states that has not done so, but almost every other state has had rural hospitals close over the last couple of years. What we've also seen, even if their hospitals are maybe still staying open, there are really, really significant risks of those hospitals closing. From a financial standpoint, they've really, really, really struggled. And there are list after list and research study done after research study that says that even though they may still be open today, the chance that over the next several years we'll see more and more hospitals close and really be unable to make payroll and shut down a pillar in their communities. And then on top of that, if that isn't already kind of glaring and dooming enough, the other thing that we see is even if hospitals maybe today are financially somewhat stable, what we're seeing is the ability to provide care in these areas with higher level type of physicians and specialties. Just difficult to get physicians to go to many of these small communities and be busy and be able to also have a lifestyle where they're not working 24/7, 365 without a partner to help them support and care for those communities. So the data is real. There's a crisis. And then you add some of the social economic scenarios that we see in many rural communities, and this isn't in every rural community, but often in those communities, we're also seeing there's often more unemployment issues in rural communities, which often leads to some other social economic issues that include, poverty. And sometimes there's higher rates in many communities of potential drug abuse and behavioral health issues. And then with some of the socioeconomic issues, we also see a higher risk in many rural communities of more chronic conditions. And really, when you think about that mix of potentially individuals that may need care a little bit more, but we're seeing more and more doors close, I think it's pretty easy to say we do have a crisis on our hands.
So speaking of the data, I'm glad you're here, David, because I know you as a data scientist have actually gone in and seen some of this data for the rural healthcare crisis, and you have a lot to talk about when it comes to that. Teach me. I want to know more.
Yeah, I agree with there. There's a pretty significant crisis, I'd say, and it's multifaceted, and there's many reasons that are flowing into it. I think Eric talked about some. I think realistically, we're seeing kind of the collapse of rural America right now, in many aspects. We're seeing income gaps, education gaps, as well as just kind of a lot of infrastructure in rural areas is kind of aging and dating, and there isn't the funding to replace it, and that's leading to all sorts of things. And more and more people are choosing to move to like where there's jobs, and so there's employment issues. But like, I don't want to get into a lot of that, but to answer your question, previously I had the privilege of working for a very good healthcare organization that primarily served very, very rural and remote communities. And someone who worked a lot with that data, I saw gaps in care. I saw that, there were outcome deficiencies where, rural communities were seeing outcomes that just were not up to standards. And it's sad. And I think some of the challenges of this are, like Eric kind of talked about this a little bit. When there's like in critical access hospitals, you can't keep a lot of the specialties. You can have in your emergency department, maybe some other specialties, maybe some internal medicine specialties, but you can't necessarily have all of the high level specialties immediately available to those people, to people in those rural communities who might need them. And it's because there isn't the volume there. Like if you're talking about some very rare conditions, maybe like, pediatric endocrinology, there probably aren't the volume in rural areas to keep a couple pediatric endocrinologists at a critical access hospital. And so for patients who might need those services, because that happens, even though there's not the volume, there still are patients who have those needs. If those needs arise, that's not available, and then they have to travel huge distances to potentially find those things. And all of these things lead to problems with outcomes. And then there's other things, issues around, trauma. If you have some type of a, healthcare issue, emergency, there's this concept known as the golden hour, where, you have after an event, after, it's an adverse condition, you've got about an hour to get to a high quality healthcare center, or outcomes really start to drop. And if you are 2 hours away from a high quality healthcare center, or 5 hours away, that golden hour is just not possible.
So if I had to summarize the crisis, then it really just comes down to access in times of need, right? And the fact that geographically speaking, people in rural communities are further away from the access. Is that accurate?
Yeah, I think access is certainly probably the core problem. I think there's a whole bunch of things that exacerbate it, though, right? Where you have people, and all of us, right? It seems like we're living with more and more chronic conditions, and there's people that are sicker and sicker, and we're living longer too, right? So many of these things add up, and then when you have a need for specialty care that maybe can't be done in the emergency department or in the family medicine clinic, now all of a sudden you're in a spot where it's like back to David's point, oh gosh, I've got to travel 2 or 5 hours to go see that specialist. And wow, then you start to see some issues with that, and even greater access problems and care problems.
And then along with that, I think it's worth bringing up kind of like the levels of healthcare. And Ron, I'm not sure if you're familiar with this, but there's this concept
I'm
of
not.
primary level of care, secondary level of care, tertiary, and then quaternary. And these are associated with medical facilities. And so a primary care center, that's going to be like, a local clinic, potentially like a critical access hospital. A secondary care site is going to be, maybe like a sort of a step up above a critical access hospital. Tertiary level of care, that's going to be a regional medical center. And then quaternary level of care is going to be your big medical centers. Oftentimes they're associated with academic centers, but not always. And within all of that, with each step up in care, you get access to more specific specialties. And so with each step up, you have a better chance of being treated by a physician and medical staff who have specific training for your needs. So if you have an issue come up out of the blue that's rare, chances are you're not going to have a physician or medical staff at a primary care center who have direct experience working with your condition. But at a quaternary level of care, you will. And so you'll be able to get that better level of experience to meet your needs at those higher levels of care. So for me personally, I live in what some people consider to be a more rural area.
The middle of nowhere.
Some people say that, but I live about half an hour from a secondary level of care hospital, and about 2.5 hours away from a tertiary level of care hospital, and about 7 hours away from a quaternary. And so this concept of rural healthcare crisis. This hits close to home for me.
Yeah, that makes a lot of sense.
Yeah. So, having described that, Eric, um, we live in this new era. We're not bounded by the same problem. We have the same problems that we've always had, but there's also new technology that can allow us to really start addressing these things. So, how is new technology allowing us to address these old problems with new solutions?
Yeah, I think it's a great question, and maybe let me go back and let's go within the walls of a quaternary medical center today, okay? And maybe a teaching quaternary medical center today. Patient comes in that setting, let's say they come in for some type of a respiratory disorder, and the physician goes and starts to provide care, and then they realize pretty quickly, like, "Oh gosh, well, it might be endocrine related or maybe it's cardiac related." And in that quaternary center, in many quaternary centers, and you've got access to those subspecialists and those teams that are there 24/7, 365 that you can consult with. And as a team, you can make decisions on how are we going to care for this patient. And it's set up in a way, again, because of volume and economies of scale, you have enough patients coming through those centers where you're able to walk down the hall. And the comment I'd maybe like to say is, hey, I know a guy who knows a gal who's going to help us answer your health question. Correct. And that model works in these big centers. But as we stated earlier, in those rural community hospitals, there may be the family medicine doc and the emergency medicine doc. And when you get to a spot where, hey, they've got more and we're not sure exactly what to do, they don't know a guy who knows a gal who can then come consult, right? And so often the perspective is, well, let's send you to the big city and hopefully you can get that care that you need. So as we thought about this problem historically, and I'm speaking for myself, Eric Liston today, but obviously employed by Intermountain Health and was part of building this work that we've done, we started to think about this of really how could we bring that cerebral part of medicine, the consultative part of medicine, and bringing together these subspecialties into these small rural communities without having to put somebody in an ambulance where they're moving many miles away from their family. And, let's say in the situation if they just had a baby, they're playing out zone defense where the baby's moving to a big quaternary center in Salt Lake City. The mom's still stuck in the hospital because she just had a baby. And now the dad's going with this baby and you've split up families, even some of those difficult situations. And so we had the idea of, well, gosh, I talk to my kids on FaceTime all the time. Like so much of this is cerebral, right? And following your medical experience and the guidelines that are built within our systems. How could we use technology to go have that consult and to have, if it's a respiratory critical care doc that needs to jump in and help advise that local emergency room department on, yeah, the blood pressure is really, really high and I suspect this. Let's do these 3 or 4 things before we put them on an ambulance and send them to the big center, because once they came to the big center, this is what we would do. Let's let it play out and try to avoid moving patients to those big centers. And that was really the context of this. That was the beginning of trying to solve a problem of saying, we're sending people away from their homes to get care, where maybe if we could build this consultative model to use the physician protocols and that deep subspecialty expertise to help the local rural communities keep their patients local, let's do it. And so now it's really, really, really fun for me, right? The initial idea was this principle of how could a critical care doc consult via telemedicine to put their eyes with a great camera and audio to see a patient and make an assessment and be able to talk to the local team and then use their expertise in critical medicine to help decide, let's keep the course here. We'll watch with you. If something begins to go where we think they need to be in an ICU, we'll help you move them. They'll be on the right protocol as we move them to the ICU. But let's do these 3 or 4 things first, and we think we can keep them there. And together, with me watching over your shoulder and making sure that we're a team, let's keep them in that local community. And it really began with just that principle: a camera, an audio visual, and a doc with subspecialty expertise helping the person on the ground keep that patient in the local hospital. And that's how we did it.
Yeah. Eric, the very first time I heard you describe, I thought that this is one of the most important innovations that I've heard in a long time. And granted, I'm biased. I'll acknowledge my bias. I live in a rural area. I care about that. So, but what this means is you've just normalized the playing field. Yeah, everyone can have access to the level of care that they need potentially. And you did it using
yeah.
old technology. You didn't have to do this with, newfangled software or anything that's not vetted. You did this with old-fashioned video conferencing equipment. And that's
We
very,
totally
very
did.
well vetted and established technology. So like it's not like it takes a lot of the risk out of it. And I thought that is just brilliant. Simple, brilliant, and effective, and it directly translates to patient outcomes. Which I just think that is
Which
just incredibly powerful.
Help me understand a little bit more about this technology, because if it is just, like FaceTiming my doctor or something, or having someone else hold up a FaceTime camera where I'm like, hey, like, you got to check this out. Like, I hit my head. Am I okay? I don't know. Like, it seems like you would need a profession or someone professional, like, there. Like, I don't know, like, what if you need some kind of emergency surgery, right? This doesn't solve everything. I hate to be the pessimist here, but like, maybe I misunderstand the technology. Like, like, what is the technology exactly beyond kind of like what we were describing with essentially just like a FaceTime, or like how we're talking to each other right now? Like, I can't just operate on either of you right now because we're all in very different locations, right? Or what am I missing here? I feel like I'm missing something.
Yeah. Rylan, I love the question, right? And maybe let's talk through this in words of a potential example, right?
Yeah.
And maybe that'll help frame this a little bit. And I love to frame this story in the picture of a little kid, right? I'm a father of 4, and so let's frame it in this picture, father of 4, and I'm in a rural community. My kid falls off the garage. He's playing on the garage, falls off the garage, somehow hits his head. We believe there's some type of a concussion, right? So go to the emergency department, and you show up there at the emergency department, and this great emergency room or family medicine doc who, very well trained in family medicine, very well trained in general medicine, but certainly becomes a little bit over their head when it comes to head trauma in a pediatric patient. Again, very different in that scenario. So Rylan, our experience historically has been, you hit your head pretty hard. We're not going to do surgery here, but we're worried that there might be enough swelling. And the only way that we're going to know for sure and be ready to take care of you is to send you to Primary Children's Hospital, just in the case that maybe there is some type of swelling and we're going to have to open up your brain, right? And that was the process. So kid hits a head, unless it was very, very, very minor, we were putting them on a helicopter in some scenarios or in an ambulance and sending them to Primary Children's, 3,
Which
4,
costs a
5,
ton,
6
I'm
hours
guessing.
away from their. Yeah, right.
Yeah.
And so now, again, so here's that story again. Family medicine doc says, yep, I'm a little bit worried. This could be the worst case scenario. Let's be safe. Let's go. Versus now, hey, I've got a camera in my emergency room department. I've got a physician who's literally sitting at Primary Children's who takes care of kids 24/7, 365. I've got even a pediatric neurologist that's sitting around the corner. Let's get on the phone, get on the video, let me lay eyes on the patient. I can do some testing, right? Just, hey, where are your eyes moving? What are you doing? Again, you can do that on a camera. You don't need any newfangled technology to do that. There's an opportunity to say, let's do this imaging scan. Let's look at it. And you know what we found in that small population? We wanted to try it first, right? What we found is less than half the time, those patients that we sent to Primary Children's, we didn't need to send them anymore, because the physician and their expertise and their cerebral knowledge and experience of head injuries with kids was able to say, we can manage it. Let's observe you in place, get the right tests, get the right images, and we can do it here. And you think about that, the fact that now more than half of those kids who we're going up to the big city to get this done. They have the same outcome. They don't even have to leave. And it didn't take any new technology. So I think that is the story. It's utilizing a subspecialist with deep expertise in one form of medicine to be able to zoom in that specific condition that the generalist maybe just felt a little uncomfortable with because it was out of their training scope. And we kept them in that local community with that extra support at the elbow support over a video.
I see. So this is more about using the technology to know when and when it's not appropriate to actually use the resources in the healthcare system to bring people up to the specialists, because some of it can be handled because they can talk through their ear, and hence you're saving money, you're saving resources, you're saving across the board. You're, as David was saying, you're kind of democratizing, giving the power of the specialists all the way down the chain through this technology. That is pretty cool.
Yeah. And Rylan, here's the thing that's interesting. And, we talk a little bit about technology. I think the technology is a vehicle, but the magic that is brought is you're bringing team-based, highly sophisticated specialists with their corresponding partners. If it's a respiratory therapist, it's a pharmacist, right? Their expertise into that small community hospital or rural hospital. It's bringing the big city to the rural community. And you can't, from an economic standpoint, there's no way and again, let's say this rural community hospital is flush with money. Even if they were flush with money, you're not going to be able to recruit that subspecialized pediatric trauma doc to go to that small community because they wouldn't have enough work to do, right? So there's just this, it's one of those scenarios where I think sometimes 1 + 1 = 10. We're benefiting local communities, we're benefiting the local patient with big expert, it's really beautiful to me.
So at what point are we sometime in the future going to have professionals or experts in very particular fields wearing those VR glasses and have some robot in a rural community that reenacts exactly what they're doing? And then you can actually not only do everything you're doing already, which is incredible, but also have even surgeries and stuff performed remotely. I'm just daydreaming here, but that seems really cool.
So that's already being experimented with, Rylan. Actually, robotic assisted
nice.
surgeries, and having a very adept specialist, maybe hundreds of miles away, who is working with a robotic assisted surgery, in some remote area. That's already being piloted. So
That's awesome.
yeah, we'll know more in the future. Yeah. So I'm also a father of 4. My children are pretty little, and they dominate my thoughts the majority of the time. And living in a more remote area,
Your thoughts and your time and your
Yeah.
money, all of those things, right?
Yes, yeah, my life.
Yes.
But I have a nightmare scenario that something will happen, and we're too far to get them the care they need, and this just helps resolve that. And then kind of like what you said earlier, it's not quite a nightmare, but another really bad outcome is the thought of, if we, when something happens, I panic. I'll fully admit that. I panic when my kids get hurt. And if I panic and go in and it's not as bad of all that, I don't want to have to deal with that bill. Those big medical bills can be bankrupting. And so it's, my wife and I always have the discussion. I wish we didn't have to, but we always have the discussion. Do we take our kids in? So-and-so has been throwing up all morning. Do we take them in? A lot of the time the physician says, let's just watch it and see what happens. And then you get a big bill and you just go home and watch. And nothing changes. And sometimes it does matter. You go in and they say, oh, I'm really glad he came in. We had to catch this on time. And when the stakes are high with those really specialty needs, this really helps triage that situation. It prevents the need to really, if I had to send my kids down to Primary Children's in Salt Lake City, that would be one heck of a medical bill. And one really stressful situation. I mean, family would have to split up. Someone would have to stay with the other kids. It would just be an awful, awful, awful situation. And the thought of being able to prevent that, except when it's really needed, is just something else. So this is quite the thing. So, in your view, what does this mean for the future?
Well, I maybe I'm being a little too much of a Pollyanna here, but I am much more bullish about our ability to keep rural hospitals alive, and that opportunity for us to bring that big care to the local communities and help patients, but by doing so, also keeping patients in those local hospitals where when you think about it, the finances are tough for these small local hospitals, community hospitals, that if they could have 2 or 3 more patients in beds for a couple days out of the month, that might be the difference of them being able to make their payroll, right? And so this economic engine of being able to keep patients in those local community hospitals, yes, it's good for the patient. And yes, it's good for them even financially because they're less expensive than being in a big level 5 trauma center. But that principle and perspective of being able to keep those local community hospitals vibrant because we are taking care of them instead of sending them, it's a big deal. I think the other piece for me, and maybe again being a little too much of an optimist, but I've seen it in my experience is, those patients who also stay local, they also visit the local gas station and maybe have dinner at the local restaurant. And I look at this as also, some of the biggest employers in these communities are the hospitals. And as we keep them vibrant, or maybe vibrant isn't the word, maybe that's too optimistic, but as we keep them solvent, we're helping more than just the healthcare in the hospital. I think we're helping the communities, and it gets me going. You can see that.
It is that time, the time that we get to benefit from Eric's expertise. It is 1 minute for 1%.
I think this is a great topic. How can we be just a little bit better in our health? And I'm going to take a little bit of a different spin today. There's lots of things we could do: eat healthier, stress a little bit less. But I want to share something that's been on my mind this whole week. And that is, I think if we all treated each other with a little bit more love and respect and patience, that would go a long way in our health. Both the benefits of being able to feel like we're helping each other and bringing people along, but also leaning in with love instead of leaning in with anger. I think it would be a big benefit to the health of us and for those around us. So maybe I'm being a little bit too much of an optimist here, or maybe too much of a realist. I'm not sure. But my tip today is let's love one another.
I love it. No pun intended. No, that's great stuff. And thank you for sharing your expertise and all this wonderful stuff about how, healthcare at the end of the day is people taking care of each other. And so I think the love that you talk about is exactly what's warranted. So thank you for tuning in to Health Elevated. If you liked what you heard, please give us a thumbs up or positive review. We'd love to hear from you. Let us know what you think by leaving a comment. Check out the Health Elevated podcast on your favorite streaming platform.